Hello, everyone. I am Ryan Hopper, the founder and CEO of ScriptMR, a new healthcare market research company. I've been in this industry for about 20 years now, and I've worked in both the sales and operations for firms specializing exclusively in healthcare, like Sermo and Manthan, and others who do both consumer and healthcare in Greenfield Online and Critical Mix.
Hi, my name is Mike Epps. I've been in the industry for a little over 10 years now. I too have worked primarily in the healthcare industry. First job out of college was on the operational side with a company called World One, which eventually became Sermo. From there, I've also worked at a company called M3, and I am the Chief Revenue Officer of Scriptamore.
Hi, I'm Adam. I'm Senior Director of Operations here at Scriptamar, and I've been in healthcare market research industry for about 10 years, mostly on the qual side, but also being on sales. And my most recent, right before I joined Scriptamar, I was leading the qual team at Sermo.
Perfect. So now that we're now all introduced, I just want to kind of explain really briefly what we're trying to do here. So we are hoping to be a resource to people both in the industry and those that are new to the industry. We will be discussing trends and changes to the space while focusing also on emergent technologies such as AI and how we see them being used in the future.
Yeah, and with this platform, we hope to be able to bring on industry experts and former colleagues and friends that we've worked with in the past that we think can provide you with some knowledge and maybe some funny stories from time to time about things that we've experienced in our careers, and we think you're really going to enjoy it.
In the future, as Ryan said, we will be discussing different topics such as difference between consumer and healthcare research, a difference between fielding in the US and any other market, match list, AI, new technologies, conducting proper patient and payer research, and also bringing experts from end clients, research designers, data collectors, so we can provide a more rounded perspective on these topics. But before we get into today's conversation, I want to remind you that this is just us sharing our experiences and opinions from working in this industry. Nothing here should really be taken as official guidance or legal advice. This is more of an open conversation between people who have been in this space for a while. So now that we're all on the same page, let's jump into our first topic. Today we're going to be talking about the difference between consumer and healthcare research. I will be moderating and we'll walk through some of the key questions that we see come up all the time. Ryan, because you've worked across both, how do you typically describe the difference between consumer and healthcare research?
Well, thanks, Anne. And as a starting point, I kind of want to use a line that I had been using for years in this industry, and that the difference between consumer and healthcare research is really that it's the same but different. Kind of weird, right? Look, every area that we have is there's similarities. You're talking quotas and subquotas. You're talking LOIs and IR, field time considerations. All of these things apply both in consumer and in healthcare research. The difference is that everything in healthcare is a little bit more challenging because the universe size is much, much smaller. There's just fewer orthopedic surgeons, for example, than there are, say, iPhone users. So because of that, longer LOIs, lower IR studies, they're going to be more of a challenge. Field times are generally longer anyway because of these smaller universe sizes. But on the bright side, you don't need 1,000 oncologists for a study, which is good because A, it'd be way too expensive, and B, you'll never get it done. So the good news there, though, is you don't need those huge numbers. 50 to 100 in most specialties in the U.S. or in some cases smaller in Canada, for example, or the EU, because there's less divergence of how behavior is around prescriptions and medical procedures. There's less of a variance in the types of answers that you're going to see. So those 50 to 100 become more accurate than, say, you need 2,000 people to do a political survey. So, one of the other things to really keep in mind, though, is this smaller universe size also means that the delays and some of the things that you may try to do in a consumer study, like extending field time for the full 2 weeks, or hey, this is what people answered on a Tuesday versus how people answer on a Friday. Those things don't really apply in healthcare. Don't be cute. Don't delay. There's not a lot of physicians. They're very, very busy. They have a lot of other options. If you have the opportunity to get a response from a physician, get that response. Don't wait. Don't put it on pause as often as you think you need to. Just let these studies run. And always remember that if you have a high LOI, low IR study, they can be done. Just be prepared that with these universe sizes, it's going to be a little bit more expensive and it's going to take a little while longer.
Thank you, Ryan. That was super helpful. Micah, when Ryan mentioned about the smaller sizes and of this small size universe, what do you think that means scaling up? Is it really realistic in healthcare?
Well, it is possible to get those larger sample sizes that some clients will ask for. The main driver for that is the LOI, length of interview, the incidence rate, and the amount of time in field. Those are really the biggest keys that we see when we're doing these larger sample studies. I recall a study we ran at a previous company where we were able to get it was over 500 oncologists. Now, granted, the incidence rate was 90+%. We had, I think, 9 weeks in field, and we had up to 15 to 17 different panels or partners involved in it. There's some difficulties with that because you have a ton of exclusion lists, and you're working amongst a bunch of different panels. So you really, it's beneficial to have one kind of point of contact that's running all of that to ensure that you're avoiding any hiccups once in field. But it really is just the will and dedication of the project teams to get that done. And if you have the time and the budget and IR and LOI that's reasonable, then those high sample size projects are absolutely doable. It's all about setting client expectations, really, making sure that your clients understand this isn't going to be a 5-day quick turn type study, because there are other avenues that we as a panel partner can provide in terms of custom recruitment and such, that if we have the time and field and the budget to do it, we can expand on those larger sample sizes.
Got it. So possible, lots of more logistics, and keeping everything and everyone organized. Now that I'm talking to you, what do you think is another major difference between healthcare and consumer research?
I think one of the biggest differences I've seen in my experience is the cost of doing research in the consumer space, B2B versus healthcare physicians. The healthcare is obviously more expensive. You're going after a smaller niche audience, as Ryan pointed out, and these folks have a lot more education behind them. They have a higher income level. So to get their interest, it does take a little bit more money, and therefore there are challenges in that aspect. But throughout our experience, we've tracked all of that data on what is actually drawing a good response rate to get the amount of completes that we're looking for. The downside to that is in all research, you have consumer research and healthcare. There are people that will try to skirt the system, and that's where you're looking for speeders and cheaters and flatliners and all of that. But most panel companies, and especially here at ScriptMR, we are adamant about implementing all the different types of data checks and quality relations that we can to make sure that we're kicking those people out, not allowing them to participate in future studies, because it's not only a pain to you, but it's also a pain to us. So we have IP blockers. We do deduping. We vet our panelists to a greater degree. So even geo tracking is another way that we do it. So all those things combined really try to help us control the amount of bad data that we could potentially see.
And we love that philosophy, and it's super interesting. And well, this ties into compliance and data handling as well. So, Ryan, is there any additional consideration in healthcare when it comes to privacy and regulations?
Absolutely. And for starters, I mean, it's important to note that in consumer research, data privacy and et cetera is still very important. But when you do get into the healthcare space, whether that's patients or whether that's physician data, sorry, protecting that information is crucial. With laws around HIPAA and in Europe with GDPR, healthcare firms and healthcare research people, like the folks in that industry, must be extra cautious about the data. The sharing of personal identifiable information, or PII, you will hear that term a lot, is much stricter. Data transfers, passing along those personal details, it becomes much more complicated, and there's much more of a process basis behind it. This is especially true in Europe under GDPR, as well as other considerations such as CNOM and the anti-cadeau or the anti-gift laws in France. So the thing to really keep in mind is when you're dealing with healthcare, you are dealing with people's most private and important information. So all of the firms throughout the entire supply chain need to be aware of those rules, understanding that passing this information, storing this information, and eventually, in certain cases, deleting this information is much, much stricter when dealing with healthcare.
Yeah, I think on this portion it's also super important to emphasize that this becomes even a more critical thing on the qual side because identities can be more easily revealed in interviews. In focus groups or moderator boards, there is a much higher standard when it comes to protecting respondents. At a minimum, we need to ensure informed consent is clearly obtained, strictly limiting to the collection data and sharing of PII, maintaining tight control over how recordings are stored, accessed, and used. It also requires active moderation, and by this I mean being intentional about guiding participants away from sharing sensitive or identifying details and making sure everyone involved in the process is aligned on data handling protocols. Ultimately, protecting respondents' privacy is not just about compliance. It is fundamental to maintain the trust and integrity of the research. But yeah, there are a lot of differences. But I'm sorry to interrupt you, Ryan. What else comes into mind from an operational standpoint?
Not all. That's actually very, very helpful. So I think one of the things also that comes to mind, if I put my kind of operations hat back on, is that understanding the information in healthcare across the spectrum of who's looking at it can be very challenging. For example, most of us drive a car or have a cell phone. We watch TV, or in my case, enjoy the odd bag of chips, something like that. But how many of us really know the prescription habits of a colorectal surgeon? Or what cutting tool works best for the incisions of various surgeries out there? The answer, virtually zero. So what does that mean to you? Well, a QA who's looking at your data, or a project manager who's building your survey and trying to analyze how skip patterns are or are not working, it's a lot more of a challenge for them to understand some of the intricacies of this research and how you're trying to do it. So if question 13, 15, and 18 are relatable to you, that's great. And if a project manager or the QA doesn't understand how those things should relate to each other, you can't assume that they can make that leap on their own, or that information is going to jump off their page, no matter how many episodes of Grey's Anatomy or The Pitt that they're watching on a Thursday night. Any kind of information that you have along those lines, keep those lines of communication open. Share that information with the QAs and the project teams. That way you're all on the same page. You can move forward. Find those spots in the data that aren't kind of syncing the way that you want. Figure out a solution together, and don't make those assumptions because the information is not nearly readily available as it would be in a consumer study on any of those other previous topics.
Fine. Ryan, thank you. Mike, is there anything you'd like to add here?
I think I think data removals is really important to consider here. especially when talking about the difference between healthcare and consumer. In consumer research, you're going to have a lot more data removal than you would in healthcare research. For instance, I think it's probably in the 30 to 40% range on the high end of consumer research that might actually get removed once you're doing data checks. And a lot of that is just because you're going out to people who aren't as experienced, maybe, and so maybe they're not understanding the question properly or answering it properly or whatnot. But when it comes to healthcare professionals, these are people with highly educated folks that know about their industry and have to be certified through CLE type programs and so on. So when you're talking about data removal, the high end that we ever like to see is maybe 10%. And I think that's probably on the high end. If it's any more than that, then it might bring some more questions about it than answers. So I really like to see it much lower than that, but I think that's one of the key differentials between consumer and healthcare that people should keep an eye on as they're getting their data back.
Great points all around. Well, I think the main take is that healthcare research can feel a bit intimidating at first, but many of the fundamentals are still the same. It really comes down to understanding the nuances and working with the right partners to navigate through them. So thank you so much for listening to our first episode of Short Script. If there's anything you want us to cover or questions you see come up a lot, let us know. We'd love to hear from you. Thank you again, and we'll see you in the next one.
Thanks, everybody.